I would like to thank Duke-Ruhuna Link for sponsoring us, myself and Lakman, for this Duke Scholar program, and also giving us the opportunity to be here and with you and learn more about research, and also giving this opportunity to share some of our work with you. And also, at the beginning, I would like to thank the Medical Microbiology for providing help in our critical situation to manage this outbreak at down at Sri Lanka at this moment, especially for providing immediate on-site laboratory testing facilities. Okay, so we'll move to today's topic. Myself and Lakman will be talking about the dengue in Sri Lanka, its birth and challenges. And this first I will be talking about this epidemiological pattern of dengue in Sri Lanka, and Lakman will touch on the clinical and more practical problems with that. To start with, this is the flow. Like I will touch on the infection and then the global distribution, and then about the landmarks and the epidemiology of dengue in Sri Lanka, and then a little bit about the research we've done there. So we all know that dengue is a frequent cause of acute febrile illness. It's there all over the world. This is a virus which belongs to the flavivirus family and having 4 serotypes, named as dengue type 1, 2, and 3 and 4. It's transmitted by the Aedes mosquito. Aedes aegypti is the principal vector, and the Aedes albopictus. The infection with this dengue mosquito leading to a serotype-specific immunity, that is, infection with one serotype gives rise to immunity for the same serotype, but not for the others. Because of that, if the second infection is due to a different serotype, we get a more severe infection, which you may end up with dengue hemorrhagic fever or shock syndrome. So this is the global distribution of dengue. You can see in 1970, very few countries were affected, and the serotype distribution is unequal. But by 2011, you can see most of the tropical and subtropical countries are affected, and almost all countries have the distribution of all 4 serotypes. So this is mainly due to the urbanization, globalization, trade and travel, on top of poor vector control activities. So by now, 50% of the world population live in areas where dengue virus has the potential to be transmitted. So on the trend. So with that, I move on to the Sri Lankan situation. So these are the landmarks of dengue in Sri Lanka. The first serologically confirmed dengue was found in 1962. 3 years after, in 1965, we had the first outbreak. And 1989, that's a very important milestone. Yeah, we had the first ever major outbreak. And in this time, we had more cases of dengue hemorrhagic fever, more severe cases were there. And after that, in 1996, we include dengue into our list of notifiable diseases. After that, you can see gradually, every year by year, the number of cases going up. These are some other changes in the epidemiology. One of the important changes is the shift of the affected age group from children to adults. You can see by before 2000, it's mainly a childhood. This is with mean age around 15 years, but up to 2000, mean age increased to 25 years, affecting more young adults. This is the pattern of cases across the year. You can see 2 main peaks. First peak, which refers about infection, will arrive on usually the June-July period, which follows the first southwestern monsoon. And the second peak, much smaller, towards the end of the year, which follows the northeastern monsoon. So the 2 monsoons will create more breeding places, so the vector density goes up, that will in turn reflect the increased number of dengue cases. Initially, the dengue fever was known to be an urban disease affecting more crowded areas, but now it has moved to the semi-urban and even the rural areas. Again, initially those appear as sporadic cases with epidemics placed in long intervals, but now everything changed. case number is ever rising, and we have outbreaks every other year, every 2 years time. And there are changes in the breeding habits also. Usually these Aedes vector, they breed on clean and organism-rich water collections, maybe artificial, maybe natural, but they have adapted to lay eggs in brackish water. So being an island, having coastal line overload, so we are still pretty high. Right, so this is an interesting slide. You can see the number of dengue cases in Sri Lanka starting from 1992 going up to today. So it's rising every year. So I have marked 2 major outbreaks, one in 2009, having 35,000 cases and 346 deaths. And out of that, the highest outbreak we had last year, accounting for 186,000 cases and 421 deaths. So when compared with the 2016 level, it's about 4 times higher. So we had a tragic situation here last year. So about this year, so far until May we have 18,000 cases. So you wonder why I put different colors into this bar chart. Right. So just to highlight about 3 studies I will be talking later on. So we did one study in 2017, one on 12-13, and another on last year, and we will continue until next year. So just to keep an eye, which I will be discussing later on. A little bit more about 2017 outbreak. You can see these pictures, the areas affected by dengue. You can see by 2017, the country is almost dark red, affecting almost every area. They are in the big country. And out of the all cases, the western front is affected, the bad, which was 41% of all the cases. And we, the southern front, they are really affect about 9% of all cases. And what is the reason for this? So we suppose isolate from this outbreak is dengue type 2. It was not there in the field for last 10 years. So sudden emergence of type 2 may have resulted in this type of situation. And on top of that, there are some predisposed. So as I mentioned, so we had heavy floods in 2016. Also the monsoons and also the waste problems contributing to that. About the heavy flooding, so this diagram shows the flood affected areas in the country in 2017. So the highly affected areas usually represented by the higher dengue burden. This slide shows the age distribution of the dengue patients, and this outbreak, you can see 30% of patients are of school age. That's the situation in the country as a whole. But now I move to the southern region where we are from. You can see it's down there, Bengal. It's a beautiful city with a lot of attractions, popular tourist destination. Well, we can say the Galle will be the second highest population city, and also it's having the second most highest burden of the dengue as well. So we have to play a major role in dengue control. So how we contribute to this dengue situation for the country? It's mainly by collaboration between the Duke University and the Ruhuna University. So we have this collaboration since 2007. It's ongoing. And we are happy to say that we did 2 main studies, which I mentioned in the previous bar chart. So these 2007 and 13 studies, they have already completed. And started the third one last year. But I and myself and Lakmal contributed for the last one. So, but I'll be briefing about the first 2 studies to give you some idea about the epidemiological change. So this was the study for the previous two studies. The teaching hospital in Karapitiya. It is the only tertiary referral care center available for the whole southern province. We did the research involving medical and pediatric boards. This is how we collected samples by the help of pre-intern medical officers. And their work has been closely monitored by the senior research colleague in our study group. Here we can see we had a separate area in the outpatient department to have the television vision of the patients. And we obtained samples during the acute stage as well as the emergent stage. Moving to the 2007 study in detail, you can see in history we easily call it as PIVA study. So it's funded by the Duke University and the National Institute of Health. And we had enrolled 1,079 patients, and out of them, about 80 patients, we had both acute and emergent samples. So we tested these samples, these tests, IgG and IgM for dengue, dengue PCR, virus isolation, and neutralization studies. So these tests were done at the University of North Carolina. And the results of this study is published in 2012 in Emerging Infectious Diseases. So I'll extract some of the important things from this. You can see the whole study cohort, PIVA cohort, and out of that, only 6%, 6.3% account for dengue. So it's not a common cause at that time. Out of this 6.3%, only 14% were clinically diagnosed. So that's important. So this is the distribution of dengue cases across the age groups. You can see it's mainly affecting the young adults and adults. This slide shows the seroprevalence. You can see it gradually increases with the age. In childhood, the prevalence is low, between 10 to 20. During serotyping, we identified that most of the viruses belong to type 3, dengue virus type 3, and rest belongs to other group 2 and 4. But no dengue virus type 1 isolated at that. About the second study, Sri Lanka emerging acute respiratory and febrile illness characteristic study, and this is funded by the Global Health Institute. Study setting is more or less similar to the previous study, but in this one, we didn't enroll the outpatient. We only took the inpatients with dengue. Again, acute and convalescent samples were obtained, and they were tested for dengue IgG, RT-PCR, virus isolation, and some of the samples we provided with genome sequencing. And these tests being done at the Duke-Ruhuna Link. The results of this study were published in 3 papers, and I will extract some of this data. We had a total of 976 patients. Out of them, we had a paired sera from 90% of patients, so it's more than the previous study. Majority of patients were male patients, and about 30% were below 18 years of age. Interestingly, we had a larger cohort of dengue this time. We had nearly 40% having confirmed dengue in this study. This is the distribution of cases across the age. You can see again mainly in young adults. Seroprevalence, similar pattern, increasing with age, but you can see now prevalence in children gone up. Previously it was 10 to 20, now gone up to 20, 30, 50. And this time we had facilities to GIS mapping of cases. So that of colleagues in the Duke. We were able to map it, so you can see the location, and the area. You can see the hotspots. These data are still not published, but on the very soon they will be published. And this is more helpful to identify the and trace the cases and do the control activities. Another slide of this epidemic, you can see this epidemic. We are mainly affected by the secondary dengue cases. The majority of the red line are in secondary dengue cases. During the phenotyping, we found that more than 90% belongs to dengue type 1. So totally different picture from the previous picture. And when we further genotype this subset of the samples, we found that majority belong to dengue virus type 1, genotype 1. Apart from the main publications, we have presented our data in many other local and foreign forums. So with this picture, you can see the local picture as well as what we see out there, other drawings. This changing epidemiological pattern is a threat for the control activities of dengue. Therefore, we need continued surveillance and also research to detect these changes as early as possible and to take necessary action to prevent the occurrence of future outbreaks. So with the experience of the 2 studies we have already done, we have planned the ongoing study with the help of the Duke team. And that study not only involved the patients in the Galle district, we have expanded into the 2 other districts in the southern province, that is Margaret and Hapa. And we get all the patients from not only the tertiary care setting, the secondary, and also at the base level, hospital level. So a wider group of patients we expect. And also, not only looking at the epidemiological aspect, we have expanded this study to include the high-risk factors or the markers or the problem with the burden. So all those things will be addressed by the next. My friend Lakman will talk more about this third study in his presentation. Thank you.
Okay, thanks Gaya for setting up the stage nicely. So, so now we are going to move ahead to a different aspect, move away from epidemiology and more think about the predictors and also the economic aspect of dengue, which is much more important in our setting. Because mostly we rely on the clinical features, in the day-to-day management. We tend to not come across a lot of high-fi diagnostic at the time. So my talk has 4 segments mainly, so clinical presentation and pathogenesis, I'm going to briefly mention, and then about the previous studies that have been already done about the predictors of dengue severity, a snapshot on the 2017, the largest outbreak that we had, and then about the ongoing dengue surveillance study which is ongoing at the moment. So the first one, so this is, ladies and gentlemen, this is briefly about the clinical presentation. For the people who are familiar with it, dengue starts from the mosquito, the virus gets into the body, and then it gives rise to the usual viral infection, febrile phase of dengue, which is indistinguishable with the other viruses, and it has high fever, rash, aches and pains, nausea, vomiting, retroorbital pain, and we cannot really, unless doing a test, we cannot really identify whether it is dengue or other viral infection. So a proportion of these patients, roughly 5 to 10%, goes into the severe disease, the severe dengue category. These people have severe bleeding, as well as that they leak into their body cavities, maybe the pleural cavity, the lung cavities, and the abdominal cavities. They leak fluid because of the pathogenesis, which I'm going to describe in the next slide. So these people are very prone to get these complications and morbidity and mortality of dengue in this category. So we have to keep a really good eye about this severe dengue category. So this is to just to highlight what is the importance of understanding about dengue pathogenesis. Because all the other diseases that you know, if you get it for the second time, basically you have good antibody response and you are basically protected, isn't it? But dengue, usually it has 4 serotypes, so basically you can get dengue for 4 times, maximum 4 times for your lifetime, isn't it? So when you get dengue for the second time, you get an exaggerated immune response and you get leaking and bleeding more than that you get in the first time. So imagine if you go to Sri Lanka, you get dengue for the first time in your life, so you'll be fine mostly. Okay? I can say that. So, but if you go for the second time and you get dengue, you are heading for trouble. But luckily if you go for the third time and fourth time, again, your severity goes down. So second time you have to be very careful, apply all your repellents and be under the nets all the time in Sri Lanka. Okay? So when we are thinking about the antibodies, so imagine you get the antibody response after the first time you get dengue. Okay? So these antibodies are formed. But when you get the second time for the dengue, maybe from another serotype, these antibodies from the first time does not work really well. Actually, they are detrimental because it causes an exaggerated immune response by the monocytes and will increase the viral load. The cytokines, a lot of cytokines are secreted and they go into like severe disease. This is another depiction of dengue, how it happens. It enters the body and replicates inside the macrophages and gives rise into there's a T cell response. Yeah, you have it.
Did you get the same, the same version of dengue the second time? Do you get the severe response or do you get a normal immune?
Yes, when you get it for the second time, you have an exaggerated immune response because these non-neutralizing antibodies, which are formed in the first time, they attach to the monocytes and macrophages and also to the antigen-presenting cells, and they present it to the T cells, and the cytokine response, the cytokine storm that they create is so profound, they go into this stage of capillary leakage. So
does that only happen if it's a different serotype, or does it also happen if it's the same serotype on the
same
second
serotype? Usually you are protected for the second serotype because we are infected with dengue serotype 1, and if you get the dengue serotype again, you are basically protected most of the time. But when you get to another serotype, because that's why I said you can get 4 times dengue for a lifetime, if you are lucky. So this time, so when these inflammatory mediators are released, and these go and attach to this capillary endothelium and cause the capillaries to leak outside the fluid, right? So they first leak a lot of what you call serum, right? So they first leak the waters into the abdominal cavity, then they can leak blood. So then you are heading for trouble, you are going for severe dengue category. And fortunately, or unfortunately, I don't know, so this critical phase of leakage only happens for about 2 days, 48 hours, which we are, in a way, we are lucky, but we are heading for trouble in that phase. That's why we call that phase the critical phase, where you need extensive monitoring. You monitor certain parameters and you look whether the patient is going into shock stage or leakage stage profoundly. So we can give them fluid resuscitation and recover them. So you might think, okay, we are protected from dengue, we are in the US, far away from all those countries. But this is from 1865, where Inspector General in Royal Navy from the US, he describes about the dengue that they have at that time in 1800s. So he says that it is known to accompany the yellow fever epidemic seasons, and also that he suspected a ship which is coming by, which is possessing bad hygiene conditions brought with the epidemic of dengue. So you have still ships coming in, a lot of flights coming into Sri Lanka, US, and this is the way that you can get a dengue. And also, it says that certain areas, Burma and India, those places there have been epidemics, and also Philadelphia and Georgia, also in that list, and they have said all concur in that it became a general epidemic in southern United States in 1820. So that is long ago. But then, it took about roughly 100 years for people to realize that there has been a dengue shock syndrome, that people go into this severe category. So in 1964, people have described this shock which is associated with dengue, because initial dengue has not been such a bad disease. And now, ladies and gentlemen, now there's a dramatic increase in global incidence in dengue, and about half of the world, including y'all, are at risk of dengue, unfortunately. It's spreading rapidly. So I've come to the second part of my talk, which is the previous clinical studies on the predictors of dengue. And since 1950s, people have been trying to identify the clinical predictors, or the laboratory predictors, which would predict severe disease in dengue. So because of that, so people have created certain case definitions as well. There have been several case definitions up to date. So CRO 2011 has been the most recent one. So the predictors of severity can be from 4, which is clinical predictors, laboratory predictors, radiological or sonographic predictors, you can say like that, and also there are social determinants that are important in dengue severity. So this is one study which is recent and from North India, where they have described about a 2015 outbreak that they had. And roughly 50% of the people have had dengue fever, and out of those, roughly 50% have the severe disease. And dengue shock syndrome and dengue death, it's about 12% and 6%, but when you're comparing it to the numbers of 350, it's a big number. So they have predicted that the age more than 24 and the late presentation to the hospital more than 5 days is a significant predictor of dengue severity, which is very applicable to our tropical countries, because people mostly, because of the access to healthcare, because of the knowledge of regarding dengue, they can present late. So this is a very important predictor. So other than that, they have coined up many clinical and radiological laboratory parameters: abdominal pain and vomiting, and leukocytosis, bilirubins, creatinines, and also some sonographic evidence of gallbladder wall edema. So these people who have this have more prone to get severe disease. So this chart also represents the all on your left side. Basically, this all the parameters which are here are predictors of death in dengue. Although the numbers are small, so they have not calculated the odds ratios. So, but these are all detrimental to have it in stage of dengue. And one important statement that they have made in their study is 80% of the patients referred to our center succumb, which is a pretty big figure when it comes to mortality. So we have to concentrate on these people who get in transfer as well. There must be some problems in the transfer. Also, they have not specifically mentioned these are the problems that they have faced during the transfer, but it's an important area to look for. So this is another high study in which they have tried to define certain laboratory parameters in dengue severity. So people who are having the low white cell counts, low monocytes, and low platelets counts, so they are more prone to get severe disease. And also, if the hematocrit is lower, they are more to get more profound dengue as well. That is not from people who know about dengue. Dengue people get hemoconcentration. So usually they have a higher hematocrit, the packed cell volume, we call it. But people who are having clinically bleeding and leaking when it comes to dengue, they can have more severe disease. We can explain it like that. So another systematic review and meta-analysis, they again defines all these parameters. This is the extensive list. And importantly, there are some social determinants that we must not forget in tropical setting. In this article, they have mentioned that ethnicity, educational status, poverty, income, and the behavior, the social behavior, and also there are some health system dimensions that we should not forget. The knowledge of the doctors about dengue management, the knowledge about the patients as well, the referral centers, all these account for maybe the late presentations and also the severity of dengue. So the 2009 criteria defines all these problems. They have three categories basically: probable dengue, dengue with warning signs, and also severe disease. But if we go through this, so there are some subjective parameters here, and if you say it is not very user friendly, so we applied this to one of our studies that is previously done. So, and out of the 300 laboratory confirmed dengue patients, met the diagnostic criteria of 2009, and for 74 or 25% had no warning signs, and 73% was categorized into these warning signs, which is the bad area of dengue that we should be very vigilant on in our management. But if you get clinically, 9 patients had evidence of plasma leakage and 16 had evidence of bleeding. From this total, this is kind of a low number that we are looking at. So we are thinking whether this WHO 2009, whether it overestimates the amount of dengue, because the problem in dengue is the people who are bleeding and people who are leaking. So we cannot look at all the dengue positive people. So we must get that cohort of severity. So we must look at that category specifically. So then again, the Sero classification 2011 came in, and then they categorized 2 important parameters that we can specifically and objectively look for: evidence of plasma leakage and thrombocytopenia less than 100,000. So that is more objective. So the third part, I'm going to give a small snapshot about dengue. It's the largest outbreak in Sri Lanka. And you must have seen the wards. This is one bed, and this is not any person who is looking at blood pressure measurements. There are 3 patients in one bed. You see here there are 2 beds with 4 kids. So we faced this outbreak, massive outbreak last year, and it was a very bad time because all wards are crowded and we were running out of clinical facility, getting exhausted, and we had a very rough time. So we have to do the PCV or the hematocrit measuring by using these small gadgets that we are having. So we don't have to look at all the full blood counts always. So we can monitor the PCV with this. And also we had to look at the pleural effusions by clinically tapping onto their lung bases. And also we need a lot of monitoring equipment, infusion pumps and all that. But now, there's been a shifting management of dengue. Now we have ultrasound, bedside ultrasound scans in almost all the wards, in the medical wards. So rather than tapping them clinically, which is the pleural effusion detection is quite late, we can sonographically detect leakage in a quite an early stage, so we can early detect them and concentrate on the dengue hemorrhagic fever category easily. So this graph depicts, you see this is the scanning from the side. So this is the liver and this is the diaphragm, and ideally you must see the lung, sonographic evidence of lung here, but it is totally black, which means that there are a lot of fluid collected there. So these are other images. The right on your left upper hand, there's the depicted from red arrows are the fluid which has accumulated between the kidney and the liver, and it has increased in the second picture. So this is how the patients start leaking. And also in the abdomen, you can see some bowel shadows here, bowel, and this is the uterus. And there is fluid collections inside the abdomen as well. This is how the people leak, and we can easily detect from sonographically before getting them detected from the clinical examination. So we came across overburdening numbers. There was great stress in the clinical facilities. There was exhausting of the healthcare workers, exceeding bed capacity, and we were managing patients mainly on the floor. We had to give them mattresses and manage the patients on the floor because we didn't have enough beds to accommodate those people. And because of this overburden, the Sri Lankan guideline recommends the hospital admission only when the platelet count is less than 100,000, which is going hand in hand with the Sero classification, right? So we did not have much data so how is the yield of severe people detection when you are only concentrating on the people who are under 100,000, which we are going to talk about from our study. So this is the ongoing dengue study which I am having. So this is the study, the clinical predictors and surveillance of severe dengue in southern Sri Lanka, which is going on for like 3 years. Now we have passed 1 year now. So from the Ruhuna and the Duke-Ruhuna collaboration, we are conducting this. The funding is from National Science Foundation in Sri Lanka. And currently we have recruited more than 1,000 patients over nearly 1 year. And we are performing surveillance in the 3 major districts. And our goal is to make Galle a reference laboratory, so the people can easily reach to when they require lab testing. So this tiny bit is Sri Lanka when you compare it with the US. And when you expand it, we are doing it in the southern part of Sri Lanka now, involving 3 districts. And these are the number of claims that we came across. So we are going to predict the clinical and laboratory predictors of severe dengue. And also we are going to predict the clinically significant signs of early plasma leakage. And we are going to, maybe we can formulate an algorithm to categorize for the triage patients who are needing ambulatory care or in-ward care. And also there could be a sentinel surveillance, and we are going to assess the economic impact, and we are again going to use GIS and see whether there's a hotspot patterns are different from the last study that we have done. So the method is the prospective cohort study. We are starting in 2017 June. And in 3 hospitals, and we are recruiting patients who are only under 100,000 of platelet count. So we are mainly targeting the severe category of dengue. So these are the inclusion criteria. So the results, after 5 months of recruiting patients in only Galle district, we came in 414 patients, a mammoth number of cases. And from that, 323, 78%, and were laboratory confirmed dengue. And the median age, if you can remember Gaya's talk, initially it was, in first study it was 15, then it was 25, now it's 33. The dengue is getting older, I guess. So now, we have 78% cases with dengue at the moment. So then we are coming to this severe category. So from the dengue hemorrhagic fever, the people who start leaking, there are 59% of the people out of the dengue cohort started leaking, which is kind of indicator of severity, right? And then out of those, the people who are leaking, 59, which means 18.3%, develop severe dengue, which means they have plasma leakage with the respiratory distress, they have severe organ failure, they were shocked, and they have severe bleeding. But when we use the classification of 0, when we target patients less than 100,000 rather than the whole cohort of dengue, we came across that 30% of the DHF develop severe disease. So, which is an important figure. If you can detect people who are leaking, either sonographically or clinically, we can say 1 out of 3 patients might develop severe disease. So this is a stage that we can really concentrate on rather than concentrating on the whole cohort of dengue, isn't it? So also we have looked at the severity markers, and there were the females, the white cell count, low platelet count, transaminitis, which means dengue-induced hepatitis, those are predictive of severe disease. But in our study, we did the R-sound scan to detect leakage. So we came across this interesting finding where if a patient on admission have leakage, fluid detected in the pleural effusions or in the abdomen, which is Morrison's pouch, meaning the area between the liver and the kidney on the right side. And also if you have pelvic fluid. So if these fluid leakage signs are measured on admission sonographically, you can see that the patients are, it's very significant, the patients are heading for trouble. So very important finding. So the economic impact. So you must be very proud these days that you are kind of in relation with the royal family. This isn't it? The US and royal family is very close together now. So it was going these days, the Megan's wedding dress and the wedding cake is not that expensive, you know, not much of cost spent, you know, everything is going on in internet. And this says the royal wedding, if you see here, the total cost in red is 2.7 million. Which is good for a royal wedding, isn't it? But if you see down here, it says plus security cost 40 million. Which means always you must not look at the red figure always. There is always addition, you know, going on underneath, you know. So basically the total is 42.7 to be exact. So it's important to look at the dengue as well. So other than the hospital, the expenditure that we are having, when the patients get admitted to the hospital, we are having certain expenditure from the health sector, which is free in Sri Lanka. But addition to that, there is another health economic impact when it comes to other areas, which I'm going to mention later. So this area that we are going to tell is about data regarding direct patient expenditures, travel, medical visits, medication, investigations, and we are going to concentrate about the indirect costs, loss of productivity because of dengue as well. So we have studied like 323 patients, and overall, and we gave calls in about after 2 to 4 weeks of, after discharging to get the data. And importantly, if you look at this figure, overall, 249 patients reported 1 to 4 prior outpatient visits for the same illness, which means before coming to the hospital, they have been seen multiple times by the general practitioners. And of course, there's an expenditure there. The GPs in Sri Lanka, they charge money. It's a kind of in the private practice, kind of a private sector. So there is expenditure happening there. And when you come to loss of productivity, 72% of adults have missed work roughly for 3 days. And this is before admission, ladies and gentlemen, before admission. And children, 39% have missed school for 4 days. And then we did a post-discharge call to find out when have they gone back to their normal duties, normal work, normal schooling thereafter. Surprisingly, we saw that most adults reported missing work following discharge, median 14 days. 2 weeks they were off work. And children, mind you, again 14 days, 2 weeks they were off school, which is a very big figure, and this came as an astonishing figure to us. They were basically out of everything for 2 weeks. This may be due to the post-viral, syndrome that is happening, aches and pains, you don't feel well, you can't, appetite is gone, something like that. So expenditure, ladies and gentlemen, the national average income in Sri Lanka is about $7.2, which is the cost of a burrito in downtown Galle. So then the total median expenditure is $13 US. Mind you, it's 2,050 Sri Lankan rupees. And it finally boils down to this number. Before coming to the hospital, they were basically spending 1,350 rupees before getting admitted. And after getting admitted, the healthcare is free, so you don't have to spend a penny on that. And thereafter, you have to spend like 800 rupees after discharge as well. So most of the expenditure comes from before admission, maybe because they are seeing the general practitioners very frequently. And when you calculate the median cost of days of work lost, which is a very high figure, 24,000 roughly is $155 in wages were lost by an adult by illness. So we are losing a lot of productivity because of dengue, especially in the post-discharge phase. So the conclusions, so there's overburdening in hospitals in Sri Lanka and other tropical countries due to dengue. And also we should find out predictors to try the patients to take important decisions to see which people need inward care, which people need ambulatory care. And then we have to define what is the economical burden that we are having. We didn't have any figures earlier. And this data will all be useful one fine day for the public health, authorities, if they are caring about this. So to want to triage patients, to decide on a triage criteria, which patient should be admitted, which patient needs care, and also to help to inform about the vaccination and vector control activities. So these data can be all useful for that. So thank you very much, and thank you all for accommodating us, and thank you all for giving this opportunity to speak as well. Me and Gaya, both of us enjoyed the time in Durham. See that. Nice places in Durham, and also drive across in other places as well. But you are most welcome to visit this place as well. And remember, if you are coming for the second time, nice stuff and we pack your necks up. Right. Thank you. If there are any other burning questions, both of us can entertain those. Yeah.
Do you have any idea why it's getting older and affecting adults more than children?
That I'm not pretty sure why it is in age is becoming higher and higher. One thing is the people who are having the primary dengue is usually our children, right? So they might be getting more and more asymptomatic. But when you get for the second time, which is the older population, they are getting, because the numbers are increasing, people who are getting infection are also more increasing, and maybe because of that, the people who are getting secondary dengue are getting more and more, and maybe those people are the ones who are getting admitted to the hospitals mostly. Maybe that's the reason. But if Gaya, if you can add anything for that, why the median age is increasing?
I think you're correct in the sense that a lot of primary infections are happening in the younger children, and so what we've noticed is that it's usually male adults who are getting exposed, and so when they're outside in the fields, I think they're just getting exposed during their work days. So that's one of the reasons, at least.
Yeah.
Is there much by way of vector control activities happening yet?
There is a lot of vector control activities happening, but unfortunately we are seeing in every country, even in Malaysia, Southeast Asia, all these countries, the dengue is rising at a rapid rate, very annoying rate, I would say. But vector control activities are happening. But lesser when it comes to Colombo, if you see the Colombo figures, those are very high. So vector control activities which should happen higher is happening less there, but in Galle is much, much better. And maybe because of that, we are having the lower numbers in Galle. I think we should find out why. That's a great question that you're asking.
And what are the vector control? Which vector control?
Maybe you can
mainly the cleaning of places, the garbage, collection of garbage, that's one area. And second area, there are a lot of social mobilization, there are social teams, and put in new legislations. If you're found to be having drinking places in your house, they could be fined. And there are teams going on every week to visit your place, and they are giving a monthly chart to see whether your holding place is okay or not. So it's being done in a more serious way, but still problem is there because some people, they are trying to do it only within their premises and they don't go into the outside. So outside the next door, you're getting a lot of breeding places. So, and also there are some abandoned places, and we have a big problem with the garbage. Garbage, so those are the problems that we face.
And fogging also.
Yeah.
Spring.
Yeah. Fogging, but the effects of fogging will last for only 2 to 3 days. That will target only the adult mosquito, but the next generation will come out in 3 to 4 days.
Thanks, that was a wonderful pair of talks. You showed, in your first talk, you showed a country map in 2 different years with a high distribution on the coast and the south. But that was absolute numbers, I think. Is that, when you look at incidence, is that just there are more cases because there are more people, or is the incidence also higher?
Incidence also
in those areas, okay. And why do you think that is?
So one thing is, again, the number of cases are going up due to the mosquito density going up. And also we get time to time the serotype changes. you get suddenly a serotype, and that's why in the last 2013 outbreak. So if type 2 was not there for last decade, when it comes suddenly out, the majority of people are not being immunized, so it's a serious outbreak.
Is there something different about those parts of the country that makes them more prone to?
Well, usually the western province and the southern province are the most populated area, the capital, and southern we are the next. So that's why the majority of people are.
Yeah, sure.
Do you think global warming has any impact on the increase in incidence in terms of spreading to other districts in relation to the changing climate in Sri Lanka?
Yeah, of course, you know, the vector, vectors act in to a certain temperature, isn't it? So maybe that's why the hill country does not have dengue much. You know, the vectors are not, maybe they cannot fly that high, you know. So maybe when the global warming is setting in, not in Sri Lanka, the vector can move on to other countries as well, you know. So that's why there's a global burden of dengue. The dengue is traveling north. Yes, sorry. So traveling north, because of that, even the other countries can also get affected in the process.
So thank you, that was terrific. My name's Andy, and until a couple of months ago I was working in Sri Lanka. And unfortunately, my wife was one of those people who got infected last year. What I heard, a couple of things that would confirm what you're saying, is that a couple of reasons why it spiked in the last year. One, dengue 1, that new strain.
Dengue 2.
Dengue 2 came to Sri Lanka, and there was no immunity. So somebody imported it off an airplane. And then the second was, maybe this is going to your climate change question, there is more and more severe flooding. Last year was the worst in decades in the south, Mathura, Hamakota, Galle. And so what makes this an even bigger problem is not only the vector, the disease spreading, but the whole infrastructure and social protection system gets severely weakened, was severely weakened last year during the flooding. I mean, there were districts that just shut down in the health system. They just shut down. People couldn't move. One reason why people can't get to the hospital is because they couldn't move physically. And it took several days for the government and the military and the NGOs to sort that out. And I think that combined just made an impact.
Yes, exactly.
Worse.
Yeah.
This is about 2/3 of the country. 15 out of 25 is badly affected.
Has government thought about trying there is a Sanofi vaccine for it. I know it isn't great, but when you have 200,000 cases, is it worth it?
Yeah, it's because of this. One thing, there are a lot of questions about the Sanofi vaccine. Currently, the Philippines has, rejected, taking it, and there are problems with that. The problem is there's a big question about the vaccine-enhanced disease. Because the patients because our people, they are mostly, when you inject the vaccine for a patient who has already got the primary dengue, that's fine. You get the vaccine and you're fine. But if you are vaccinating a non-immune person, and then you get the first attack of dengue, that technically acts as a secondary dengue, isn't it? So people can get hospitalized, they can develop bad dengue.
Have they developed that dengue?
We don't have the vaccine at the moment, but the data is that, data is not convincing, because when the Sanofi vaccine is injected to the children, those population, actually the cases has been higher. The hospitalized patients has been more. So because of this problem, our government is not yet prepared to, say, and you have to spend a lot as well, and not prepared to say yes for that request. And the people are now questioning the efficacy of vaccine. But in the future, there are other vaccines which are coming in, such as Dengue, which is a Takeda vaccine. That is, the trials are ongoing even in Sri Lanka as well. So we have Sri Lankan cohort as well. So that has people say that that has a less vaccine-enhanced disease, and you get more protection for dengue 2 serotype as well. So maybe we are heading for a good vaccine, but for this thing, if there's a vaccine, it's great in our country, if we can afford it. But unfortunately, there are questions in this vaccine, so we are not saying anything to that.
What is the percentage of people that have the shock fever that actually die?
Sorry?
The people that develop the severe dengue.
Yeah.
What is it? How many of those die? Do they all die? Do they get leakage and bleeding to die? There's no. What is the percentage?
That's why they have guys fall. So we give fluid resuscitation, we give blood transfusions. That's why the critical phase, that 48 hours, we keep the patients on monitor the whole 48 hours. We check their bloods, we check their blood pressures and everything. And depending on the fluctuations, we give necessary fluid resuscitation and blood transfusions. That part is really complex when it comes to dengue management, how the PCV and platelet fluctuates, how the hemodynamic parameters fluctuate, and when the patient is leaking, or when the patient is bleeding, when the patient is leaking and bleeding low. You have to correctly identify that phenotype of dengue, and if you treat accordingly, you can reduce the mortality. So in our study also, there is minimum number of deaths, unless there is late transfer or something, late admissions to the hospital, unless that, we are learning on dengue and we are really good at managing dengue. So by that we can reduce the mortality. Although the patients go into shock and all that, there are ways to manage.
And do you think the ones that do develop the severe one, does it have to do with the type of care that they had and how long they waited for care?
Yeah, but of course, it's again a social determinant of mortality in dengue, because if you present late when the patient has already bled and leaked a lot, if the patient has already gone into a profound shock which has gone on for several hours, then it is difficult for them to reverse. If the patient is having metabolic acidosis, respiratory distress, myocarditis, the heart is not working, if everything, if you come in the end of the spectrum, it will be really hard task to get them back on track, But that's why these early indicators are very important. Advising the patients to come to the hospital early, and maybe scanning them, clinically detecting them early, and identifying the severity parameters, and monitoring them very closely in that 48 hours. That is the way to reduce the mortality, because we don't have a magic drug to give for dengue. It's very cost effective to treat dengue in a way, because you give only fluid and maybe blood transfusion. You don't have
dengue. I had dengue. I only took, stuff for fever and water.
Yeah, that's fine. You got it drinking here?
In Brazil.
In Brazil, okay.
It's like 10 years.
So maybe your primary dengue as well.
And I've been there, many times, but never had the bad ones. So.
I think we should wrap up since people may have to go. But if anyone has further questions, just talk to the speakers. Thank you everyone for coming.
Thank you.